If you want to think about what is a controversial area in Crohn's disease, it really has to do with what is first-line therapy or how to treat the low-risk patient. People in years past have used mesalamine for that. It's not indicated from a regulatory perspective for Crohn's disease, and that's really because the clinical trials have not shown benefit. So my personal view is that mesalamine therapy doesn't play a role in the treatment of mild to moderate Crohn's disease. People sometimes use antibiotics. Again, they're not indicated for that, and there's a variety of public health concerns, including risks of Clostridium difficile with antibiotic therapy, so I don't use antibiotics unless it's to treat perianal fistulas and abscesses. And that really leaves steroids. So for patients with ileal Crohn's disease or right colon Crohn's disease, ileal release budesonide works very nicely in those patients, has a low side effect profile. For patients where budesonide doesn't work with that anatomy, and for patients that have more extensive colonic disease, I'll use prednisone. And then the question from there is, and this is an area of controversy, should patients who get prednisone, because of the high relapse rates when you stop it, also receive azathioprine or mercaptopurine or methotrexate, or should you just do a tapering course of prednisone and wait and see what happens, and if the patient requires more prednisone and becomes steroid dependent, then move on to a biologic? My personal view is that azathioprine and mercaptopurine have a relatively high rate of skin cancer, non-Hodgkin's lymphoma, and infection risk, and that comes with pretty modest efficacy. So I typically don't use those drugs as monotherapy, and I'm more likely to just give a tapering course of steroids, monitor the patient carefully, and if they need something more, then just move on to combination biologic therapy.
In low-risk disease, the sequence of therapies is quite limited because we have very few agents that are most appropriate for patients with low-risk disease. We might choose to treat a patient with ileal or right colonic Crohn's disease with budesonide, but we know that that is not going to be a very effective maintenance agent, and many of those patients will end up on methotrexate, or they may end up on azathioprine or mercaptopurine as a maintenance agent. The key is to look again to make sure that mucosal healing has been achieved. Beyond that, if the patient doesn't maintain, they by definition become a moderate to high risk patient, and we move to a different protocol altogether. In moderate to high risk disease, the sequence of therapies is in evolution because there are a growing number of agents at play here. So it would be appropriate for patients with moderate to high risk disease to be treated with a TNF blocker, either as monotherapy, but probably preferentially as combination therapy with an immune modulator like methotrexate or a thiopurine agent to get the most durable and effective response. Beyond that, patients might choose to use vedolizumab as first line of therapy, again, either as mono or combination therapy. And a third option would be ustekinumab, often as monotherapy. It can be used as combination therapy, although that doesn't seem really to be necessary. Now, the question of which one of these agents you would choose for a given patient may have a lot to do with patient preferences, with particular features of the patient, with particular safety considerations. All these come into play in choosing which one comes first.